Please stand by. Good day, everyone, and welcome to today's presentation on strategies to improve treatment adherence in CTN research protocols. This session will be recorded. All participants' lines will remain in a listen-only mode. We will be opening the phone lines periodically as comments and questions are encouraged. If you experience technical difficulty, please press *0 for assistance. Now I'd like to direct the audience to force their screen to full view by pressing the small icon located in the bottom right corner of your screen. You are looking for a blue box with arrows pointing out from the corners. Please click that icon now to bring the presentation to full view. At this time, I'll turn the podium to Liz Buttry. Please go ahead.
Thanks very much. Welcome, everyone. I'd like to take a moment to thank Al Cohen and Dennis Daley for presenting and sharing their respective research and clinical practice-related expertise. Before we get started, I'd like to ask a couple polling questions that kind of helps get us started and lets us know who's joined with us today. So let me go straight to that. The first question, that's to indicate what your current position is. I'm going to let the responses accumulate for a moment. And I'll go ahead and show those results to everyone. 41% research assistants are with us today. We have a pretty good mix here with us. That's great. Now I'll move along to the next polling question. What's your level of experience working in CTN trials or research trials in general? I'll go ahead and show those results. Great, we have a good mix of experience here, and a couple people with over 11 years experience. Again, we welcome any kind of input or comments that you guys would like to share when we open up the phone lines later on. And then one last polling question. Please indicate areas you've struggled with adherence. Could it be diet, exercise, medication, New Year's resolutions? Okay, I'll go ahead and show those results. 41% with exercise. I would be in that category of people as well. That's interesting. Nice to get to know who's with us today. So what I'll do is I'll go back to the presentation, and Dennis, I will go ahead and turn things over to you.
Okay. Good afternoon, everyone. I'm speaking to you from beautiful Pittsburgh, Pennsylvania. I'm delighted to be here and to work with Liz and Elle on this presentation. The focus is on strategies to improve adherence to protocols. And this is based on both clinical and research practice as well as the literature. You know, a lot of the strategies are relevant to patients and protocols as well as patients in clinic. It's good to try to understand the problem of adherence from the inside out. That is, what's it like to have an addiction? What's it like to try to stop and recover? And what is it like to be a research participant? So try to understand it from their point of view. What does it feel like? What are some of the challenges? The more you can understand it from their point of view, the more sense it makes. And as the last polling question shows, we all have our own issues with adherence. And you could look at this in terms of your experiences with treatment. It could be medical treatment. It could be psychological treatment. It could be therapy, counseling. It could be medications or some kind of combination. Many of us have struggled with that. Or it could be with a personal change plan. When Liz showed her polling question, I thought I was one of the few people who struggled with exercise, and so you just took away my uniqueness, Liz. So they would say Daley's a protocol violator when it comes to exercise. Okay, so we're going to talk about the objectives of the presentation. First, we want to define adherence, and another term often used is compliance. So the literature will have both terms, although more recently, adherence is used more than the term of compliance. Secondly, we'll talk about ways in which adherence problems show in clinical protocols and in clinical practice. And you want to think of adherence, it's not an all or none phenomenon. It shows in degrees. So, for example, you'll have some subjects or you'll have some clinic patients who are fully adherent. They do pretty much everything. Some who are mostly adherent. They do most of what they're supposed to. You'll have some who are somewhat. They're sort of in the middle. Then you'll have a group who are poorly adherent, and you'll have the group not adherent at all. And since we use an intent-to-treat model, even if protocol patients aren't adherent to the treatment, they're still in the study, and the results are integrated with the results of the folks who do attend. We'll identify factors affecting adherence. We'll also talk about some of the adverse or negative effects on the research participant and the caregiver. Now, we don't have this on here, but I want to mention this because we have some clinicians on. You also have adverse or negative effects on family because there is a burden associated with addiction, and you also have a burden related to caregivers who get frustrated because they work their butts off, and you have clients who are poorly adherent to treatment. And then the other part of this would be the treatment systems. When people don't show up, what happens to treatment systems is they don't generate the income. That's lost income. And then the other thing we'll do at the end is talk about some strategies related to motivational interviewing, which is a approach used. It's been a standalone approach, but it's also been integrated into many protocols as well. So those are our objectives. And if we don't meet them, it's L's fault. Let's talk about the definition of adherence. Adherence basically refers to the extent to which the research protocol or the client attends the sessions of the protocol. Now, this includes assessment, and this would be the initial baseline assessment and evaluations, as well as all the other evaluations that may occur over, weeks 1, 2, 3, 4, months 3, 6, 12, 9, whatever the protocol calls for. Secondly, it relates to medication, but not just the visits, not just coming to the clinic for medication, but taking medications as prescribed, not taking too much medicine, not taking too little, or not skipping it at all. And as many of you know, that medication adherence is a major problem across a whole range of diseases and disorders, medical, psychiatric, and addiction. And then the other thing, and I already mentioned this in the assessment, is the follow-up visits. The problems may show, people may not show up, when they're supposed to come back at week 4, week 8, week 12. Now, when you look at treatment adherence and research protocols, we want to get people to get as much of the treatment as possible. Now, having said that, treatment completion may be defined differently by protocols. And I'll give you one example from this page 12, CTN 31, which was the 12-step facilitation integrated with another intervention, the goal of which is to get people to attend and get active in 12-step programs. We define treatment completion as receiving a certain dose. There were 8 sessions, and if you receive 5 out of the 8 sessions, we define that as treatment completion. So treatment completion may not necessarily mean 100% attendance, but it does typically involve attending the large number of sessions that are offered. So adherence can relate to coming into treatment, making the initial evaluation, or coming into treatment and staying engaged, session attendance, and that's a issue for many patients and many protocols. In fact, typically in clinical trials, patients are more adherent to the follow-up sessions than they are to the treatments. And then in some cases, you have adherence related to task fulfillment. So, for example, and I use the 12-step study as an example of this, we assign specific readings and workbook exercises and behavioral tasks related to 1 to 12-step meetings. So you can't have adherence, it applies more broadly, not just to coming to treatment, but doing the work that you're supposed to do, whatever the treatment is. Now, what are the benefits? I'm glad you asked. Now, from the research point of view, the big issue is getting the data. Without the data, the research is meaningless. And that's why there's so much hustle and so much time and effort put into getting people to attend the assessment sessions, the follow-up sessions, because we need the data. The data is important to do the statistical analyses related to the primary and secondary outcomes of the study interventions. And in the clinical trials network, the primary outcomes usually in most trials, the majority of trials, relate to the primary drug of addiction or the primary drug of abuse. And the significance of outcomes are based on these statistical analyses. So we need the data. That's important. If you look at this vis-a-vis the sessions themselves, the treatment sessions, typically if clients come to sessions, and this is true in clinical protocols, it's also true in clinics outside of research, is they have better outcomes related to drug or alcohol use, and that's why we're in the business. We're helping people preferably stop using substances, but reducing substance use as well. You also have better mental health clinical outcomes. People function better. They have less depression, less anxiety, or there may be other mental health issues as well that improve as people get better. Now, however, having said that, you can, in some instances, you may have clients and protocols that have co-occurring psychiatric illness that could impact on adherence. In general, in some of the studies we've done and other people have done, the adherence to sessions, if someone has substance use disorder plus psychiatric illness, the adherence of the co-occurring is much worse. And I'll give you two quick examples. We looked at people with schizophrenia, and about 90% follow through when they left the hospital. If you added drug and alcohol problems to that, the adherence to the outpatient initial session went down to about 20-25%. With major mood disorders, bipolar and major depression, about 85% showed up when they left the hospital if they had a major mood disorder. If you added a substance use disorder, that went down to about 35%. So you can, and there are other studies that are similar. So you can see that one of the challenges is if you have a client who has a co-occurring psychiatric disorder, they tend not to adhere as much as people that only have a psychiatric or a substance use disorder. The other benefits include people doing better in their functioning, whether it be work or family or health. And one of the major outcomes that is looked at in many studies now is quality of life. And typically if people improve, vis-a-vis the substance use, they're going to improve the quality of their life. And then you also have lower rates of high-risk behaviors. And here we're talking about IV drug use, sharing equipment, using dirty equipment, or sexual behaviors raising the risk of transmitting or acquiring HIV. So these behaviors, if people adhere to treatment, and because treatment typically will offer not only counseling related to the substance abuse or addiction, but also related to high-risk behaviors. I mean, that's the one thing NIDA has done an incredible job on, is integrating the focus on HIV risk behaviors. So you have lower rates of high-risk behaviors, lower relapse rates, which is very important, and related to this would be lower readmission rates to hospitals, detoxes, rehabs, or levels of care, high levels of care for treatment of addiction or treatment of co-occurring disorders. So clearly there are a lot of benefits of good adherence, both for the research and related to the clinical outcomes. And really, even though our focus is on the research, ultimately we're here to help people. Okay, identifying adherence problems. I think Al will take over here.
Yes, hi. Good afternoon, everyone. This is Al Cohen, talking to you from Los Angeles. I am the Director of Research and Training for BART, an opioid treatment program system. Thank you for joining us today. I just wanted to, before we follow through with the slides, amplify on one or two points that I touched on. The first is, for some of us, this will be, we're newer to the research arena. Some of us have much more experience. But it's always important, as Dennis pointed out, to try to keep in mind what the participants' perspective is in going through the research and in going through the protocols. It gives us a whole different point of empathy for what they're going through and not just what the research staff is struggling with. You'll hear some talk about motivation coming up. I just wanted to preface that by saying that motivation is not a singular unitary concept. It changes over time in many cases, and so when we get there, please keep in mind that if you have any questions, write them down. We'll talk about them later. And finally, as Dennis mentioned, adherence and retention in research trials depends on study participants attending their data collection points, their treatment sessions throughout the protocol. It's also not just showing up, but participating. When you attend to a treatment session or a data collection session or meet with the RAs or the counselors, it's important that the study participant is engaged and not just there to collect their $10 a day or whatever it is that we're compensating them. And with that, I'll move on to identifying some adherence problems. Let me find a little. Yes, okay, so being proactive is always a guiding principle with me and saves a lot of agony later on down the road. It's very important because of the complexity of a lot of the research protocols that you'll be involved with, that it's hard for staff to understand all the nuances of these protocols. Imagine what it must be like for participants to understand and grasp what's expected of them. But it's critical that we make sure that participants do understand not only the overarching goals of the study, but what they can expect, what's expected of them throughout the course of the protocol. You cannot adhere to something you do not understand. So as you all know, some of you more better than others, the consent process is very complicated, time-consuming. A lot of the people that we have in our treatment populations may not have a lot of patience. But some of the consent forms, as you know, can get extremely long and complicated. Still, it's our responsibility to make sure that we do the best that we can in explaining to the study participants what the expectations of them will be throughout the study. Again, the screening and consent, the early phases of your recruitment are critical for doing this. You don't want to get halfway through and have study participants tell you that they had absolutely no idea that they were going to need to get blood in this study or that they were going to need to spend as much time as they do in the study. And proactive adherence protection. By that, in talking with your study participants, and we're going to elucidate that several times over the next hour, it's critical that you talk with study participants, not talk to them, not be robotic in your data collection, although collecting data, as Dennis pointed out, is one of the main outcomes and goals of the research trials. But talk with them. You probably will end up seeing, research staff may end up seeing and having contact with study participants as much or more than anyone else in the treatment program, sometimes even more than their counselors. Listen to what they have to say as well, and in listening you will clarify potential issues that may present adherence or retention difficulties for everyone down the road, and then those can be proactively dealt with. What are some of the ways you gather information to identify adherence barriers that may or may not currently exist? So Liz put together this neat little slide that shows you on one side, the researcher saying, explaining to one of the study participants, perhaps it's screening, that you'll be required to be in the clinic 3 times a week, which is actually what is required in the upcoming CURB study. We're open from 6 to 2. Are there going to be any problems getting to the clinic? How would you be getting to the clinic? Will it take you very long? Starting to explore some of the practical aspects that of the study that could later on become adherence problems. The participant responds, well, I don't have any issues with the 3 times a week, but I have a court date in July, and now this is supposedly June. What would this kind of a response prompt you to start thinking about, you as a research staff member or you as someone involved with the research at the treatment program? I think here you have a participant that's presenting something that hasn't happened yet, but that may involve or interrupt the smooth flow of the protocol and attendance at the clinic. So you want to explore that fully with your study participants. So these are identifying barriers that haven't occurred yet necessarily, but that may, and it's critical that we do this. It's also critical how we do this. So constant attention to respect and motivation of the study participants will yield you a great harvest in collecting this kind of information ahead of time. I always think in terms of research studies in sections, in stages, Act 1, Act 2, Act 3. Certainly the early stage is during the time when you're recruiting people, when you're doing pre-screenings, when you're doing screening and assessment prior to actual randomization in the study. Again, we echo the sentiment that it's critical that not only the participants understand the research study, but that the staff understands the research study. I mean the staff of the program that's actively involved and engaged with the protocols, but also the staff at the larger treatment program who may not have direct hands-on responsibilities for the study, but they need to be aware of and have a working knowledge of what's going on. That'll save you a great deal of grief later on. Second stage is the initiation phase. This is the early phase of the protocol when subjects first have been assessed, accepted, and consented, of course, and then you begin the study with the individuals, randomization to one of the arms of the study. During this phase, you'll have a certain number of participants who are going to drop out. We have to accept that. Anyone involved in research for any period of time understands that a certain amount of early study termination is to be expected, although we try our best to minimize as much as possible unplanned early terminations from the study. Why people terminate early in the study versus why they terminate later on without finishing the study can vary a great deal. Part of it is that they are there for reasons that you may have misunderstood, or they may not have explained their motivation very well. So the first couple weeks of the study are really critical to setting the stage, to having a good experience for the individual, and that helps with retention and adherence. And then there's the maintenance phase of the protocol. Maintenance meaning that some studies are very long in nature. The START study was an 8-month study with 6 months of active data collection. And so people who start out in a research trial in June may feel very differently about it in October. So we have to shepherd our study participants through the study. We have to try to ensure participant engagement. We need to preserve treatment adherence, and you'll become aware of where treatment adherence is getting a little loose, and you'll attend to that. Good treatment exposure. Medications trials are always, and behavioral trials are always about treatment exposure. What dose of the experimental arm or the experimental medication or the experimental behavioral intervention have the study participants receive? Sometimes we get negative results or non-significant results at the end of the study. In data analysis, it turns out that the experimental condition is not any better than the treatment as usual. Some, and in many cases, rightly argue that it's not that that the experimental condition didn't make a difference. It's that the dose that the individuals received wasn't great enough. So if you don't get the proper dose of your medication, you're not going to get the same response as if you do get the proper dose. Where possible, so we follow protocols and we follow ops manuals, as you know. And we have to follow them fairly religiously. But these protocols are built with a certain flexibility, built in for clinician judgment, built in to tailor to some extent to the individual programs. Where possible, we should try to utilize that flexibility as it benefits our study participants. Don't be too inflexible, but stay within the parameters of the study protocol. Well, it may go without saying that you'll be able to identify areas where adherence is poor, and some of these are more apparent than others. Absenteeism at the clinic, missing appointments. Clearly, that's a self-identifying issue for adherence, and may, in fact, apply to retention as well. Retention, as you know, recruitment and retention are the two R's that the CTN lives by. So you have people who come in and they're a bit ambivalent about the study, and they go away, and they may come back several times and talk to you several times. Try not to get too frustrated with that. It's just part of the everyday work that we do. Noncompliance with study procedures, failure to give data, failure to give biological specimens, being late for appointments, which is a constant headache for everyone. Early dropout from the study is a killer. I mean, we expect that we're going to have a certain percentage of people who drop out of the treatment protocols prior to completion. I've always found, and I think some of my staff have found, that while it's always a disappointment to do all the workup on screening, recruitment, assessment, and getting people ready, which can take an awful lot of your time, still, to have someone drop out in week 1 or 2 has a subjectively different feel to it than to have someone drop out the 1 week before completion. That's always very, very disappointing for staff, and we want to try to identify these adherence problems ahead of time so that doesn't happen, or we reduce that as much as possible. Medication use and misuse goes on. Be aware of it. And I will ask Dennis if he has any comment. Oh, wait, I have one more slide. I'm sorry. Adherence challenges. So there are two basic kinds of trials that we do in the CTN, and you may have been involved with. One are medication trials, which, under the leadership of Dr. Volkov, are going strong, and behavioral trials, which we've also done in the CTN. Some of these share some of the same adherence challenges. Logistical considerations. It doesn't matter whether it's a behavioral trial or a medications trial. If people have difficulty getting to your location, it's going to affect adherence and retention. But in medications trials, you have one of the critical variables being what is the expectation that the participant has of this new experimental medication or study medication. People come in expecting all kinds of things based on what they've heard, based on what their relatives have told them, based on what their friends have told them, what they've read on the Internet. And so that subjective expectation sometimes is met or not met when they first start the medication. This can have a great impact on retention. In early phases of study, you really have to hold hands with participants, shepherd them through that difficult transition, and wait till they get stabilized on the new medication. In behavioral trials, they have their own challenges. The number of treatment sessions per week, the length and type of sessions, and the types of interventions are not always as common and comfortable for study participants as they may be for you or I. So keeping that in mind, I'm going to now turn the slides back over to Dennis for a while.
Yeah, I'm going to go back, and I just want to comment on two things, Al. One is on slide 9, which you had talked about preparing participants. I just wanted to mention that in the world of clinical care, there's a significant literature on what's called treatment induction. And what that shows is that when people are prepared for treatment, they're more likely to stick with it. And the old-timers here may appreciate this. I hope there's some old-timers on. Those of you who remember studying group psychotherapy proposed by the classic text on group psychotherapy by Irvin Yalom from Stanford talked about preparing patients for group therapy. And when you prepare patients for group therapy, when things happen to make no sense to them, they're more likely to stick with it when they understand what the expectations are and what may happen. And so the same holds true with clinical trials. So the more they understand the protocol and what may happen and not happen, I think the better it is for them, and the better impact that'll have on retention in the protocol. So, and then the other thing I wanted to mention, on slide 11, Al had talked about the behavioral child retention, the types of intervention. What you have sometimes is you have subjects who don't want the treatment they get. You know, maybe they get, individual drug counseling and they'd rather have cognitive behavioral therapy. When we did the Cocaine Collaborative in the early 1900s, it was with Harvard, University of Pennsylvania, Pittsburgh, and New Hampshire. We had 3 individual treatments combined with group, and then we had group alone. And there was a significant minority of patients who only received group treatment who wanted individual. And sometimes that's hard for the patient to want to stick with it. And certainly that was when they did a follow-up and they asked for reasons for dropping out of treatment, a number did identify they didn't get the treatment they wanted. So sometimes what happens in trials is that people won't get the treatment they want. And I think that's an issue with the medication trials, although they don't know because they're getting placebo versus a medicine. But some patients, when they hear about a medication for cocaine addiction, they're happy to join a trial, but they expect to get the medicine that will affect them positively. And if they get the medicine that doesn't affect them positively, it could be the placebo, they may not want to stick with the treatment.
Well, Dennis, it clearly applies to both behavioral and medications trials. Particularly medications trials where you have open-label trials. START was an open-label trial. Everybody knew what they were getting and that they were being randomly assigned. And it was an interesting phenomenon that the choice there was between buprenorphine or methadone for 6 to 8 months. And once you were assigned to a group, you couldn't just change. But we initially, back in 2006 when the study started, we had a huge portion or percentage of people who came in the door to explore the possibility of participating in the study really resist buprenorphine. They only wanted methadone, and we in fact found that a lot of people who early on were randomized to buprenorphine dropped out for the reason you mentioned. They wanted methadone. They didn't want buprenorphine. Interestingly enough, toward the middle to end of the trial, everything flip-flopped, and people were coming in really wanting the buprenorphine and disappointed if they got the methadone. So you're absolutely correct. Go ahead.
Okay, we want to talk about factors affecting adherence. You want to think of this as a formula, and the formula would be treatment systems, which would include all the people involved in the treatment system in the clinical trial, plus the patient or subject, plus the research staff equals adherence. And it's no different than a clinic that's not doing research. That outcome is a result of the interaction between all these different variables. So here you have in this slide, you have a number of factors. You may have child care issues, people are busy, you have transportation issues. In fact, to be honest, in our clinic, both in terms of the research subjects and the clinic patients, if we didn't give bus tickets, we would have to close our doors, because a lot of the folks who have low socioeconomic status need the transportation help. Lack of motivation, I'll talk about that shortly, and then rapport. Now, rapport is interesting because I think that's analogous in clinical work to the concept of therapeutic alliance, which is a connection. And what patients want, what research subjects want, is I want you to listen to me, I want you to understand me, I don't want you to judge me, and I think that's more relevant to adverse effects of the addiction or if they relapse or lapse. I don't want to be judged, and I want you to help me. You have to be empathic. If you connect with the patient, if you develop rapport, they're more likely to come out. And I would say this, and clinicians might get a little bit pissed off, but sometimes in research protocols, the subjects feel more connected to the research associates because they spend all this time with them than they do to the clinicians. And in the clinical side, it's very interesting because I think of a study done in the 80s by George Woody's group from the University of Pennsylvania where they looked at opiate-addicted patients who had depression and antisocial disorder. And what they found is that if you ask clinicians, well, why are your patients not doing well? They'll always blame it on the patient. But what the literature suggests is that if you have a good alliance, that you'll have a positive effect on him. But what they found in their opiate addiction study with the ones who were depressed and antisocial, the patients that were well connected, had the alliance with the clinicians, had better outcome. So, and what that suggests too is that you can have difficult patients, who like to break the law and be deviant. If you connect with them, you can influence them in a positive way. So let's go to the next slide here. I'm going the wrong way. Okay, sorry about that. So what affects adherence? And you can divide these into several areas. One is client variables, and here are some examples. One would be their beliefs. And it might be things like, well, I only need medications. I don't need therapy offered in a combined protocol. That's not too uncommon. That's not uncommon in programs that offer methadone maintenance of buprenorphine. People want the medicine. Even alcoholics sometimes only want the medicine. They don't want the counseling or therapy that goes along with it. It could relate to practical things like time and resources like babysitting or transportation. It can relate to severity of illness. So, for example, clients who have multiple addictions or those who have multiple relapses, and they may struggle more with obsessions to use drugs or cravings to use drugs, and they affect their behavior, which in turn affects their adherence. So if you have someone, for example, in a clinical protocol who relapses, they may not want to come back. Same holds true in a clinic. And I think the message we want to convey is we want people to come back whether they're using or not. I mean, we want to help people not use, but we want them to come back. The more we can stick with them, the more we can influence them. And then you might have, from the client point of view, you might have other symptoms that could be related to problems like depression. So, for example, if you look at depression or if you look at addiction, they can affect judgment. They can affect energy level. They can affect motivation. And this is really not discussed much. We know this from some of the quality initiatives we've done in our clinic, and this is more relevant to group treatments because addiction often offers group treatments more than individual treatments. And we have some studies mainly of group treatments, but most of it's individual treatment. High levels of social anxiety. So what happens is patients don't tell you I'm anxious about being in a group. They just don't show up. And so we found in one of our studies, we found about a third of the patients had high levels of social anxiety and avoidant behaviors. So if you have a group protocol, you always want to think about that as a possible factor. Now, the second category is relationships and support systems. And we know that if you have negative social networks and you don't have confidants and positive people, you're going to have a harder time in recovery. If you have a harder time in recovery, you're probably going to have a harder time adhering to the protocol. So that patients that are connected with others who care about them, mutual support programs, whether they be 12-step programs or other programs, have a greater chance of recovery. The other factor related to this is, I think a lot of the literature with adherence is very similar to that of relapse. If you look at the precipitants of relapse, the second most common precipitant with most addictions is social pressures to use drugs or alcohol. Now, it's not the social pressure itself, because most people in recovery will be pressured to use drugs or alcohol. It's whether or not they have the coping skills. But if clients don't have the coping skills to resist social pressures and say no and avoid situations or get out of situations, then their risk of relapse increases. And again, what we find in many situations, clinical and research, is that if people relapse, it's not unusual for them to decide not to come back to treatment sessions. And then the third category relates to treatment and system variables, and we mentioned this before, but here you have things like friendliness of staff. And, you know, ladies and gentlemen, I swear to God, we take this for granted, but I have seen much bad behavior on the part of staff across multiple systems. You have to be nice. You have to be kind. You can't be hostile. Now, that doesn't mean that clients won't irritate you and get under your skin, but you have to deal with that in an empathic way, because they'll pick up on these issues, and that may keep them from coming back. So I think it's important that programs have a philosophy of a certain philosophy about treatment, how they want to treat people, because unfortunately with addiction, and I talked about this, I met with a group of psychiatric clinicians yesterday, that if someone with schizophrenia has a relapse and goes to the emergency room, or someone with diabetes, they're treated much differently than someone with an addiction who relapses. You tend to get more judgment. Even people in our field tend to get judgmental about patients who relapse, or patients who say, okay, I'm going to quit the primary drug of abuse but still use something else. And then another example of a treatment factor would be the side effects of medicine. That you could be in a medication trial and have side effects that are so uncomfortable that you decide to stop the treatment and you don't adhere to it. Okay, we want to go to the next one, and we want to look at why focus on retention. I mean, that's sort of apparent by what Allan and I have talked about, but it helps with engagement and retention, and it helps people do better. So in clinical practice, outcome generally is associated with adherence to treatment. You know, there's no guarantee, but we do know the longer people stay in treatment, the greater the likelihood they'll get better. We also know, if you look at relapse rates, the highest relapse rates are in year one. Within that, they're in the first 90 days, and within that, they're in the first week or two. So the early period, if you go back to what Al said when he talked about the different phases of research, you can think about that in terms of the clinical work, that early on you have the more problems. You can have problems at any point, but early on you're going to have the greatest number of potential dropouts. And then in research protocols, when people show up, you have the data, and we talked about that before. You know, the protocols are, we do this to help people. We want to find out what helps people, but the data is important. If we don't get the data, we don't know. So we believe the participants who adhere do better. And then the other thing I wanted to mention is that, again, those with co-occurring psychiatric disorders will tend to have a greater problems with adherence. So if you have a protocol and you have some patients that have levels of, even if it's not a clinical depression, it could be subsyndromal, they have some depressive symptoms that can impact of adherence. And those of you who are Woody Allen fans, and I'm not crazy about Woody Allen, he once said that 80% of success is showing up. So again, the goal is to get people to show up. So whether treatment A, B, C, or D is given to them, no treatment will help if they do not show up. So why focus on adherence motivation? And here the guy says, I'm desperately trying to find the motivation to get motivated. We all struggle with motivation, and you go back to the question that Liz asked you before, whether it be, diet, whether it be quitting smoking, exercise plans, saving money, even going to work. So we should understand that. What is it like to struggle with motivation? In fact, if it weren't for external factors, it would be, people, you can love your job, but, you show up because you have to. You want to get paid, you have to. And what you do is you deal with periods of low motivation. Now, however, it would be nice if that same thing happened in treatment, but what happens is when motivation of a client in a protocol or a treatment program lowers, then they're more likely not to show up. Now, I'll sit in groups of patients and co-lead groups or lead groups sometimes, and I always talk about motivation because I think NIDA has done a lot of studies on motivation. And I will always ask people, how many of you felt like you didn't want to come in today? And typically 60 or 65% will raise their hands, and we'll talk about that. We'll talk about why did you come in, and we'll talk about how when subjects or patients make themselves do something, they're more likely to benefit from it. If you only do things when you feel like it, you probably won't do it very often, especially when it comes to dealing with issues around recovery from alcohol or drug addiction. So So motivation can change over time. It can change within the context of a day, of a week. Anyone who's worked clinically can see this. You can work with someone and say, it's the most motivated person ever. The next day you wonder, what the hell happened? Their motivation went out the window. This comes with the territory. Motivation is not linear, and it's not static. It changes over time. And it also, as we said before, there's lots of different motivations for why we participate in research. We do it to get help with our problem, drug abuse, drug addiction. We do it for the money, and I hate to say this, but the money is certainly an incentive. But the way I look at this is, again, this is for the old-timers who remember Father Martin's Chalk Talk, a film many rehab programs have shown in the past. There was a saying about people without motivation: you can lead a horse to water, but you can't make them drink it, but you can make them thirsty. So if we get patients to show up for the money, over time they may get interested in the protocol, and that external motivation for the money may become internalized. I'm here because I'm getting better. And I've seen that in watching videotapes of treatment sessions, group treatment sessions over time. So it's no different with, actually it is different with research than it is with clinical care, in the sense that research patients are actually, they tend to be more adherent to treatment because they have these kinds of motivating factors, whereas your typical clinic patient doesn't get paid for showing up. So I mentioned about this, and I'll go to the next one here. And when you look at motivation, we tend to think of this from a number of different perspectives. One is problem acceptance. Do I have a drug problem? Is my cocaine use a problem? You may get people who, they're not sure. That's fairly typical. And that will affect the readiness to change in terms of stopping the cocaine use or the other drug use. The other part is treatment acceptance. Am I ready to accept the help offered to me, whatever the protocol offers? And sometimes you get both. People, I have a problem and I need treatment, I want it. Sometimes you get people that they're very ambivalent about their problem. They're not quite ready to change. They may accept treatment, but they may not internalize that for a while. So you're going to have different degrees of acceptance of the problem, drug abuse, drug addiction, and different degrees of acceptance of treatment. And as I'd mentioned before, actually it's not on this slide here, but I'll mention it, that those with co-occurring psychiatric disorders have greater degrees of problems, with treatment participation. And again, get back to what Liz said before. Who among us hasn't struggled with motivation to change at some time? And I have my daughter, 26-year-old daughter. She's a newspaper reporter. She is so cool, such a lovely young person. And she struggles with her weight and exercise. And so she now has, actually this is great because she's going to be in a triathlon next month. And she's working out and she's following her program. And I'm, as a father, I'm proud of her. I'm glad she's doing this and I'm happy for her. But I reserve judgment. I've learned not to get too enthusiastic too early, because it's not how you start, it's how you finish. It's like sustaining it over time. So as we all know, motivation does change over time. Now, we talked about the relationship between you and the participants is vital. And I'm always very impressed with research staff, how well they do with patients. And sometimes I wish typical clinical staff would do the same, and I know there are different reasons for that, and a lot of it has to do with caseloads and time and these sorts of things, but you cannot underemphasize the importance between you and your relationship with the subject. And the more you're connected, I think the greater effect you will have on them adhering to the sessions, getting the data, and understanding that everyone has an impact, everyone. And then that includes people who answer the phone or people that may not be doing anything in the study in terms of assessments or treatment, but they greet, could be a receptionist, for example. I've seen receptionists in the past who were extraordinary. I've seen receptionists who were rough around the edges, and you think, oh man, I'd never want to, have to talk with him or her. The adverse effects of poor adherence, they're less likely to benefit from the intervention. They may be removed from the study. The negative effects of addiction, they increase relapse risk. The other thing, we don't mention this here, but because I always think in terms of addiction in the family, it creates a burden on the family because they're affected by a loved one's addiction. This includes the unit, the family together, as well as people in the family, individuals, including children. We have patients who have children, and there's an extensive literature on the adverse effects of addiction on children. So the more we can help adults, the more we can help children indirectly. And then you also have the impact on the protocol. It gets back to the data and all the time and investment and the resources you use and that sort of thing. Okay, Elle's going to take over and start talking. I think we'll take the last 20 minutes or so and focus on strategies to improve adherence. So let me turn it over to my good friend and colleague, Al.
Thank you, Dennis. Before we move on with the slides, let me take this opportunity to, again, thank you all for your attention. This webinar, this workshop, is really a practical workshop, hopefully intending to help you with your current and future research projects to succeed and do the best that you can with the protocols at your particular location. A couple of comments. Now, these are practical comments. These are born out of my 35 years of experience, but I think they're shared among many of you and many of our colleagues in the field. First, don't underestimate the power of money. Money is both a good thing and a bad thing. We're talking about compensation for patient participants, for patients' participation. I was having a conversation with Al Hassan this morning about a methylphenidate study that's going on at UCLA, and he's noting that the difference between a $10 payment for data collection points, because you never pay patients for participation in studies, you pay them for their time at data collection points. The difference between $10 that we're using as a standard compensation for office visits in START and the $20 that they're compensating for the same office visits in a methylphenidate study have huge implications on retention. Remember, again, as Dennis said, a lot of our participants come into treatment and into research for a variety of motivations. Some of those can be personal desire to change, but certainly coercion on the part of the legal system, criminal justice system, families, finances, for a variety of reasons, motivations drive people into treatment and into research, and they change over time. Again, we've walked that fine line between fair compensation and coercion when we talk about compensating participants for time in behavioral and medications trials. IRBs frown on too much compensation, and yet finding that right balance is always a challenge. One more comment about motivation. Please, please be aware of your own motivations, of staff motivation. This is something that we may not pay as much attention to, but it's a truism that as we progress through various studies, staff have lives, and their motivation to be in their office seeing participants on any given day may vary considerably. Also, you run across situations where staff don't particularly like a particular study patient. Then you have to ask, well, are we being as vigilant about adherence with this study participant and working as hard to shepherd them through the protocol as we may be for some of the participants who are more fond of? So staff ambivalence is always an issue, as is compensation. A lot of staff in your treatment program who are not directly necessarily related to or have responsibilities for the research protocol, and this is, as many of you know, a constant ongoing conversation, have great emotional feelings regarding paying patients or giving them any sort of monetary compensation to be in a treatment system for whatever reason. And there we have to, definitely work to erase any barriers and glass barriers that may start to develop between the larger clinic population and staff and the research staff. Everybody is there for essentially the good of the patients, whether it's through the Medicaid door, through the cash payment door, or through the research door. With that said, draw your attention to this bumper sticker that I have, and that is that successful adherence and retention in research is really a shared responsibility between you all and your study participants. You're critical in this equation. Without research staff, without the people who run the studies, this wouldn't be going anywhere. We could never get this done. But we also have to have buy-in on the part of other staff, as well as clear buy-in on the part of the study participants. How do you improve adherence? How do you improve retention? Well, we've already touched on a number of these points. First of all, within the parameters allowable by the study protocol and the manual of operations for the study, where there may be some flexibility, and that flexibility might benefit the study participant and make it easier for that participant to continue in the trial, you should consider taking advantage of that flexibility. It's not, depending on the study, there'll be more or less of it, but within the parameters designated by the protocol, give the benefit of the doubt to the study participant. Identify stages of readiness of the participant. Again, as Dennis mentioned, motivation, stages of change, stages of readiness. Not everyone is there to change their drug abuse patterns and their drug abuse behavior. Accept resistance and ambivalence as normal. Accept ambivalence and resistance as normal. I don't have much to say about that other than tattoo that to your forearm so that when you're struggling and frustrated with a patient, you recognize that in therapy, at least, in clinical work, resistance and ambivalence is used as a marker and can be built upon from that point. In research, sometimes we get frustrated because we need that data and the participant doesn't want to comply with what we're asking. You're going to run into this, accept it, and work as a team to come up with strategies to deal with resistance. Perhaps if you have more than one staff member who can work with a particularly difficult client or resistant client, maybe that's the way to go. But you'll find ways to strategize around it. You should anticipate non-adherence at various phases of treatment. People are more vested, I think, in study protocols as they start to see benefits accrue for their participation as they be, study participants often want to please research staff, want to please the research assistant, so they do things to please you, and they continue in the study sometimes for dual motivation. One is that they may be getting some benefit from the treatment arm, and the other is because they want to please you. So, but anticipate some non-adherence, and it'll make your life a little bit more easy to manage. Help clients. We talked about this in the very beginning. Be proactive. Talk with your patients. Talk with your participants. It's very important to talk and listen to study participants. Help participants anticipate personal roadblocks, like you saw in the one slide regarding the jury, the court date that was coming up. Now, we have in here, the second bullet here, it really is intended to say, follow up with your study participants. If you lose track of them, if they're not showing up, make a concerted effort to get in touch with them. We don't, in our organization, send out too many letters to people. We usually have locator data that we use to track people down. But if somebody doesn't want to be found, they won't be found. But do the best you can, and that will also contribute to retention at the end of the study, and you'll have all green on your flags and triggers reports, and that's what you want. No red, no yellow, all green. And again, I may be repetitive and a bit redundant, but it's so critical to talk with our participants. Research staff are key players. They oftentimes, as I said, see participants more than other staff do, and so it's an actual opportunity to engage with participants and patients. And the personal rapport, that relationship, Dennis talked about the therapeutic alliance in treatment, the valuable relationship between staff and participants in research can't be minimized. I'm getting a little pop-up screen here, Liz. I don't know what it means, but
I wanted to make sure that the audience had an opportunity to ask questions or comments. So if we want to ask the audience if they have anything that they would like to share with the group, let's go ahead and do that if we get a chance.
If you wish to ask a question at this time, please press *1 on your touch-tone telephone. Once again, *1 to ask questions over the phone. We'll take a question from Logan Varian. Your line is open. Please go ahead.
Well, he works for me, so that he's a little reticent to ask questions, perhaps.
So, perhaps it's a good time for me to offer to the audience another way to ask questions by using the Q&A feature located at the top of your screen. If you go into that feature, you can click QA, go ahead and type your question and hit return, and it'll prompt us with your question, and we can handle each question in so there's another option for you if you are reluctant to speak up on the phone line.
Please feel free to ask questions verbally or type them in whenever you would like.
I should just go ahead, Allan. We'll let everybody go ahead and press *1 at any time if you have questions, and the operator will take your call in the order in which it was received.
Great. So continuing with some thoughts on improving adherence and retention in your trials. There's a lot of emphasis from NIDA, from the RRTCs, from colleagues, from your treatment programs to do well in our research protocols, to represent ourselves well, to be accurate and true to data collection, and that pressure sometimes drives us to frantic levels of activity. I recommend that one of the things you do is every so often just breathe. You're going to get very busy, you're going to get very focused, you're going to get very task-oriented. Slow down a little bit once in a while and breathe and remember what you're doing and why you're doing it and the purpose of why we're all doing these things. Again, we can't emphasize too much, I can't emphasize too much, how important it is to follow up with patients. And some of you are experienced hands and know how difficult it can be to track patients, to keep patients coming in, study participants attending sessions. So that's an ongoing challenge. We stated at the beginning of all of the protocols during consent process that voluntary withdrawal from the study at any time is the determination of the individual participant, and that should they decide not to continue or should they decide not to participate, it will not affect their treatment, other treatment, or future treatment at the location. This is part of subject's protection clauses that you've all been trained in. And so we want to encourage people to get the treatment they need, to get the outside support they may need, and where needed, reassure your participants that you are also a resource for them for referral to other treatment and social services in the community. So keep vigilant about attention, keep vigilant about adherence to the study protocol. If you don't, your study monitors will remind you. Our MS monitors are very, very good at what they do, and will help us to work on adherence to the protocols and retention. And if you haven't gone through monitoring visits, look forward to them. Convey concern and empathy, that goes without saying, and be respectful and accepting of reluctant clients. Again, this goes back to the issue of resistance, motivation, and why people are there and how we treat them if they don't meet up to our expectations of why we want them to be there. So respect and acceptance of clients will go a long way for you. I'm going to swing this back over to Dennis right now.
Okay. The next slide, basically, we've covered this in many, many ways. The relationship, we talked about the importance of that. And again, I would emphasize that the research staff are often highly valued by the research patients. They feel like you care about them, you're interested in them. That's an important relationship. Related to that, again, is getting people to talk about any concerns about the study. In a sense, if you get people to open up, you can deal with it. If they keep things privately, you can't deal with it. So if there's some concern about the medicine or the treatment or the protocol guidelines, if they can talk about it, then you can deal with it. So you want to encourage them to talk about these things. Clearly, the education on the protocol. If you're in a counseling or therapy protocol, it's important to understand what's involved in terms of logistics, as well as what's the goal of CBT, or what's the goal of 12-step facilitation therapy, or what's the goal of motivational incentives. And Al had stressed this early on about the expectations and goals for the study. Don't take adherence problems personally. It's not about you, although it could be about you, mainly only in terms of if you're gruff or you're not friendly. Sometimes patients get very sensitive about that sort of thing. We had a patient, for example, that was very sensitive. We have one staff member, a little bit rough around the edges. I'm sure none of you are, or none of your staff is. And that irritated the patient. Now, the good news is the patient talked to the research associate and worked through it rather than just fail to show up for future sessions. And then using an intervention to assess what is the issue, what is the problem that's leading to the adherence problem. Now, when we say motivational strategies, there's actually two motivational strategies that have been used. One is motivational interviewing, and you wouldn't use that unless that's part of the protocol, and the other is motivational incentives. What's happening in current clinical trials, especially medication trials, is they're incorporating, all medication trials have a psychosocial component, which is good news. So they're always giving some kind of counseling with it. But it's becoming more common to incorporate motivational incentives where people earn draws from the fishbowl, and they can earn prizes, small prizes, medium prizes, or large prizes. It can be related to, it's usually related to drug use, like clean urines, but it can also be related to attendance. So, for example, in one of our clinic quality improvement studies, we gave incentives for people to show up for a day program, like a rehab program where they didn't stay overnight, and it had a significant improvement in adherence. And the good news is if you get people to show up, as I said before, you can get them to benefit from treatment. So those are some motivational strategies. Again, you want to be oriented towards the participant, towards the research subject. Now, there may be some cases in which people need other resources. It may be your job, it may not be your job. It depends on the treatment. But it's not unusual for our clients to have other kinds of needs, whether it be for transportation or for medical care or social services. Now, whether this is a referral by the research associate or the clinician, I think it depends on the protocol and the nature of the problem. But the more clients get help with these quote-unquote other problems, the more likely they are to stick with the protocol. And then motivational interviewing is just a phenomenal approach that's been highly used in the last decade or more in this more client-centered method to help people tap upon their internal motivation. And the good thing about this is in the old days, in the addiction field, we were sort of black and white. Either you're motivated or you're not motivated. And if you don't have motivation, you might be judged negatively, or you might actually be discharged for treatment. But Doctors Miller and Woolnick, when they wrote about motivational interviewing, what they said is that, look, low motivation is a clinical issue. You deal with it like you deal with anything else. Patients have cravings, or they have depression, or they have this or that. Low motivation is just one other clinical issue to deal with. And MI, as well as incentives, has been used with lots of different disorders with good results. But again, you don't do this if it's not part of the protocol. And so here's just one example. Someone says something like, I'm thinking about dropping out of the study. It's a hassle. Maybe I'll go somewhere else. And the research associate may respond by saying something like, sounds like there's something going on. Let's talk about this. You open the door for them to share what it is bothering them. And I know over the years, and if I can use a clinical example, I think this may relate to it, but if I allowed every patient who wanted to fire his therapist or doctor do it, we would have a lot of changes in therapists or doctors. But when you engage someone in the process of discussing the concerns and the problems, in most cases you can resolve the issues, and you don't have to make that kind of change. So again, it's giving an open door to talk about what it is that's bothering them about the protocol or people in the protocol. So before we open up for comments or questions, clearly from what Allan and I have shared, the adherence problem shows in many ways vis-a-vis treatment protocols, whether it's medication, psychosocial treatment, or combined treatment. It shows on at all phases from the beginning to the middle to the end, although you'll get the greatest adherence problems early up. It also relates to medication, taking the medicine or taking it as prescribed. Clearly, you have many factors affecting adherence. Some of those factors relate to the client. Some of them relate to the environment or the family. Some of them relate to the caregiver or the team working with the client and the system in which they're engaged as well. So it's not a single factor affecting adherence. Third major point is that poor adherence has consequences, and clearly related to the people with whom we work. The adverse consequences may relate to the addiction, continuing the addiction, relapse, and all the negative stuff that goes along with that, whether it be negative medical health, psychological functioning, relationships, family, spirituality, financial, occupational. Any area of functioning as well as quality of life can be adversely affected by poor adherence to treatment for any kind of an addiction. So we want to, the more we can keep people in, the greater chance we have to affect them, impact on them in a positive way. And then the other major point is, from all the studies in the literature, clearly there are a number of strategies that can help improve adherence. And the benefits, again, there are a lot of benefits to the research and to the participants. And again, back to what Allan and I have said several times, the protocols are set up to find out, does this treatment A or B, how does it compare to another treatment? How does this help clients? So that's our goal, but we're doing this in the context of scientific research, so clearly we need the data to be able to use this to evaluate the outcomes. So if you look at successful adherence and retention in research studies, it's a shared responsibility by all of staff and participants. It's just not on them, it's on us as well. And again, there's many different things that we all can do. So let's stop here. We have a few minutes. If you have any questions or comments, you can send them in via email, or you can send them in verbally.
Okay, Dennis, it looks like there's questions in the queue right here, one from Logan and one from Martha, if you want to go up to the Q&A feature and open up that box.
Yeah, I just did, okay. Which one are we looking at, Martha?
Why don't we start with Logan?
Okay, Logan says, sorry, I didn't realize I was still muted when I asked the question. When our participants have obstacles such as child care conflicts, are we able to extend the services like child care services? My belief in that has to do with the protocol more so than the clinic, but I don't think that's come up before. It may be something that should be discussed. What I would always do is, if you have a question about can we do this in the protocol, talk to the local PI and the research coordinator, and if they're not sure, they can check it out with the principal investigator. Because what you don't want to do is give certain people advantages over other people in protocols. But having said that, there may be some things that you can do that don't affect the protocol that are acceptable. Whether child care is, I don't know. In general, I know we have, from the clinic side, just to give you one example, we have a perinatal addiction program for mothers on methadone, and if we didn't have on-site child care, it would be hard for them to come to the services.
So, Logan, are you on? Well,
they are. I will go ahead and open up their line.
Okay. Dennis is correct. You know, this extension of special services needs to be thought through with respect to how this will affect the overall protocol. However, we too have a prenatal program at the site where we do our research. And if a study participant comes in with a young child and needs some time with the RA, we certainly can make available on-site temporary child care for the time when they're in their session with their RA. Some places don't have that available, so you have to work around it as best you can. Dennis also mentioned early on transportation tickets, bus tickets, other things like that can be great helps to participants in attending and adhering to the protocol.
And Logan, your line is open at this time.
Okay. Well, that sounds good. I just wasn't sure if that would be something that we would be allowed to offer if not every location had the same services.
Yeah, and what that shows to me, Logan, is creative thinking. This shows me that here's research staff that cares about the patients and what we can do to make it better for them. But again, it gets back to what does the protocol allow, because you can't have advantages to one site and not another site. So always check it out with your with the folks there and see what they say.
Great, thank you.
Okay.
Let me also just quickly comment that one of the repeating points of potential tension in treatment programs, CTPs doing research, is when standard local SOPs conflict, or how do they fit in with the protocol's SOPs as far as specific issues and items go. We had for example, a question came up on an earlier webinar regarding 5150s. When a patient starts to become suicidal or something and requires psychiatric intervention, the protocol says to do one thing. The program already has a protocol set up for that. How do you integrate those two? So this is just something to think about when you're working with your research population, that your local SOPs and the protocol SOPs have to some way to work together and not conflict. Martha?
Okay, Dennis, and now it looks like we have a question from Martha. When you have a better rapport with participants than the counselor, how do you balance helping them with linking them to the counselor?
What I would do is talk with them about, have you shared this with your counselor? I appreciate you telling me this. Have you talked to your counselor about this? The more you can tell them, encourage them to talk over these things with the counselor, the better it is for them.
And Martha, your line is also open.
And we do try to do that. I think what happens, something that was mentioned earlier, is that, you know, the counselors often aren't as available as the research staff are, and very often we're the person they come to, even if they don't have a research appointment. You know, that they know that we'll be here, so if something's going on with them, they'll just pop in and ask for us. And, of course, the support staff assume that they have an appointment with us, and they end up in our office. And a lot of times it's just, you know, we can't just say, you know, you really need to talk to your counselor about this, because it's something that, you know, really does need to be dealt with at that moment in time. It's just I guess, I don't know if frustrating is the best word, but it puts us in a position sometimes where we're kind of turning into the counselor for the participant.
Well, it's a double-edged sword. It speaks to their connection with you and their trust in you. The other strategy is to, I'm assuming the clinic is close by, is to call them and let them know this person's over here. Can you speak with them for a few minutes? Or to even connect with the receptionist and find out the availability of the counselor, and could they have the counselor call this person, within the next hour or something like that. So what you may have to do is some sort of problem solving and some linkages. And again, you're right, the line is thin between you're helping them, but you don't want to be the therapist or the counselor. You can't. From the patient's point of view, they don't care. They just want help, and they want it now.
Martha, I see we have a couple more questions, but before we move on, where are you located, Martha?
Indianapolis, Indiana.
In Indianapolis. I think my experience is always to err on the side of being more conservative. This is a very, territorial issues regarding whose patient this is and who the patient should be talking to can potentially sour staff toward research and vice versa. What we want to do at the very minimum is, at least we do, is to try to include the counselor and any information that isn't confidential that we feel is urgent that the counselor know. Then we encourage the patient to go there. And we make exceptions as far as finding time for that to happen. I know it's a frustrating issue and one that we're going to be confronted with time and again.
I think sometimes the counselors feel like they, because it's a research participant, they're maybe treating that person differently than they would someone who wasn't in a research project, because they have either myself or the RA going to them and saying, hey, this is going on with this individual and they really need to see you. And I guess it to them, it feels like we're telling them what to do and how to schedule their day. And so it also kind of presents a little conflict between the research staff and the counselors.
That's right. We don't want that. You're absolutely correct. And I think it's very important not to wait till these things come up, but to deal with them in a proactive way with when you're introducing the study to your larger staff, and bring these examples and issues up as to how will we handle this, how would you like us to handle it, understanding that we have to keep certain confidentiality guidances and barriers in place. Excuse me.
Okay, thank you.
There are no further questions over the phone.
Someone from one of our colleagues in Mexico had a question. Maybe they've left.
Yeah, I think they were thanking us. They're starting a protocol, and they thought this was very relevant to the protocol, so they were thanking us, which is very nice. I'm grateful.
That group has been joining us for our past webinars, so we give a quick shout out to them to say thank you and welcome, and we're really glad to have you on board with our webinars. It's really nice to have some international representation on our webinars. So welcome, everybody. Are there any other questions or comments at this time? Great. Okay, so what I'll do is I'll go ahead and put a plug in for the Dennis will be presenting again on relapse prevention on July 20th. That will be our next webinar. You'll see an email invitation come in the mail in the next couple of days for that. So all our webinars are recorded. They're available on the CTN dissemination library. If you know any of your colleagues that have missed the presentation and would like to give them access to it, the link is right there. They're also available on LiveLink. We welcome everybody to come to the CTN webinars. If you have any colleagues that you would like to bring on board to some of the webinars, feel free to contact me individually at ebatri@ms.com or call ctntraining@ms.com. I'm sorry, email ctntraining@ms.com. Or you can give us a call. We'll be glad to help you get those people on board. I'd like to thank Allan, Dennis, again. It was a great presentation, and it's really nice to have your expertise shared with such a large group of people today.
Thank you, everybody. Thank you, Liz, for your help.
Thank you all, too.
And that does conclude today's teleconference. Thank you all for joining.